בואו נשב כי אנחנו ממש חורגים בזמנים וכולם אחרי יום עבודה, עייפים. כן. טוב, אוקיי. בואו נשב. ערב טוב, תודה רבה. אנחנו יודעים שכולם אחרי יום עבודה, מוותרים גם על קליניקות, מאוד מעריכים, אבל חשוב לנו מדי פעם לעדכן ולהתעדכן. Our guest tonight is Steve Shack. You all know very well Steve Shack. Oncotest is representing Genomic Health for the last 11 years, and we are celebrating 10 years for Oncotype Breast this year. Steve Shack was born and raised in New York. He did his MD at the University School of Medicine in New York. Then he moved to California, joined Genentech, and he led the clinical team that gained the approval for Herceptin and Avastin, and also Pulmozyme. And once he moved from Genentech, he was the founder of Genomic Health, and developing Oncotype Breast, Oncotype Colon, and Oncotype Prostate. And today he will talk about the new direction of genomic health. But we would like to start this evening with few case studies presented by some of the physicians here. And actually, Dr. Rizel will be the first one who present. Okay.
Good evening. We are presenting a 40-year-old lady, otherwise healthy, who presented with a multifocal disease in her breast. No enlarged axillary nodes, and the biopsy was clear, so she was referred for mastectomy. At mastectomy, there were two large masses of infiltrating duct cancer, mucinous type. You see the parameters. One was 3.4 centimeters, the other was 3 centimeters. Both had high hormone receptors, no HER2 protein, and grade 3, and with a Ki of 25%, and the lymph node status was still clear. The sentinel node biopsy was clear. She had extensive DCIS around these two masses. The question is, you see that we already ordered oncotype testing. The question is whether anyone would not send the oncotype and treat according to these parameters. A 40-year-old T2N0 grade 3, 25% Ki in both masses.
Of course, I would repeat the pathology. Mucinous grade 3, it's not very common. Not very common. Mucinous are usually grade 1 or grade 2. I'm saying that mucinous tumors are usually grade 1 and 2. I would ask for oncotype, not because I'm after dinner.
Paid by oncotypes.
Paid by oncotype. I think something is not fitting. Mucinous with grade 3 exists, but is very rare. Node negative, which is usually the case with tumors, with mucinous tumors. Ki, I'm not a great believer of the test. I would ask, sure.
Okay, so we did. We brought in the TrueCut biopsy before the surgery, showed the grade 1 mucinous with Ki 5%. So we brought it into our lab, and it was the same idea, the same parameters. They read it the same. We brought in the pathology from the private lab where she did the surgery, and it was again the same. So it was again considered three pathologists actually looked at the same tumor and came with the same result. That at the surgery, it was a 25% Ki. So we sent for oncotype because we were actually also confused. And this is the result. So this confused us more. The same immunohistochemical parameters in both masses, in two different labs, 3 pathologists, and it came back with the recurrence score so different in both masses. So this is a question to you. How do you explain it?
That's great. Good. So, what clearly is great about what you've done is that when we see something that's curious, that we think isn't so typical, we take time and we get more people involved and we get more information. So actually, I know I spoke with our pathologist just again a half hour ago, and we also had our whole team looking at this together with you, and I think they worked very closely with you in terms of looking at the results. One of the things that I was curious about was the question of if this was a 19 and a 43, was what made the difference? What were the genes? And although we usually don't report all the single gene results, in a case like this, I think the team did speak with you and did go over with you what did they find when we actually looked at all of the data that is collected when we do an Oncotype DX test. And so one of the things to maybe go over, actually I saw someone earlier today who said they had a chance to go to San Francisco and do a tour of the lab. Michael, right? Yeah. So what was that like? Anyone else here, by the way, have a chance also to get a tour and see and meet some of the pathology people and see how your samples are treated? Yeah, go ahead. You have to talk loudly.
I feel like I practiced medicine in the 19th century after getting a tour of genomic health sciences and seeing the robotics and the way they work, the quality control.
Right, it's amazing. So for every gene, there are 21 genes. We were very concerned at the outset that if you had a single measure of one of the genes, and if you got a funny result, and in the lab sometimes you can get a funny result, that would cause you to get a score that was not reproducible. That wasn't able to be reproduced very quickly. And actually, in each case, right, both of the results were reproduced. So they rechecked them and indeed showed that even though the pathologist agreed with the pathologist in Israel that the tumors looked fairly similar. And our experience is, by the way, and I think it's something that Clalit and maybe Nikki would be great to collaborate together and we could share data and look at that when we've had more than one tumor analyzed. The vast majority of cases, if the tumors look very similar, the results are very similar, and I'm sure some of you can say you've had that experience before. In this case, they were repeated and they still stayed very different. So there were two things we did to make sure that we were reliable and consistent. One is for each one of the 21 genes, the assay is run in 3 different wells. And so we call each gene result based on to what degree the 3 wells look similar, and we have a very, very sophisticated algorithm to check on that. The other thing that was very interesting in this case that I found interesting is that it was mainly the proliferation genes that were different that caused the score to be 43 and this to be 19. The ER was a little bit lower in this case, if I remember correctly, than in the case of the 19, but it was mainly the proliferation genes. And interestingly, since we have multiple proliferation genes, the question I then asked was it just one of the proliferation genes, which might be a little funny, or was it all of the proliferation genes? And it turned out to be all of the proliferation genes. And so, again, I think what happened in this case is you actually got a detailed letter, and this is the letter you got from one of our pathologists. I think we have now 8 full-time pathologists and 9 consulting pathologists that shared with you all of this information. And so then the question is, Dr. Rizal, what do you do with this information? And this is now a question maybe for others, and we'll take a look at what she did. We had one very high score. Thoughts?
Well, it wasn't, it's over there.
Yeah. Here.
We considered the highest score, and of course we gave her what's common here, the common protocol of dose dense AC followed by T.
Yeah.
She's at the end of it now.
So,
Yeah.
won't it be interesting, since both are large tumors, to test another tumor blood from each? Or maybe it's tumor heterogeneity, and I think for the matter of curiosity.
It will not change the 43.
Yeah.
43
I
is
know,
43.
I know.
So
Just, yes, it's an academic thing only.
Yes.
But to
So
test-
we
to
actually
test
will
another-
sometimes do that. In fact, there was a case this past week where we had again a question where another block was sent in, and we will do that in those cases where that makes sense. Yeah.
if we suspected a higher grade tumor and that needs chemotherapy and the result would have been low, 18, 15, 16, I would have sent another block. But otherwise, this is this. So that's it.
I know, but the phenotype looks very similar
Yeah.
for both tumors. So I think it's interesting to see if it's a heterogeneity
Yeah.
or they're really the...
It
Right.
is heterogeneity because the other one is 19.
Yeah. The other thought I have, and we'll talk later about the future, is that as we think about next generation
exactly what I-
sequencing,
yeah, it's exactly what I was going
and
to
next
suggest.
generation sequencing and doing research, this would be a research question. We know that there might be different clones, and in the past we didn't have the ability to have clonal specificity. That's now possible. So we look forward to potentially doing those kinds of tests as well from a research perspective. Yeah. Was that do you want to?
That's what I was going to suggest.
Yeah.
Because it would be very interesting to see two tumors who are basically very similar, which is any specific mutation that made the change.
Right.
And we don't know that.
Right. Why is one of these more proliferative than the other? And interesting, I'm going to talk, notice these had the same Ki-67 levels, and I'm going to talk a little bit later about what we found in IHC for Ki-67, because there are, we now know real issues with looking at IHC. Okay? Great.
One
Yeah,
more thing, I
yeah.
want to show you that the smaller tumor had the highest score. And sometimes people who have 2, 3 masses take the largest one and send for oncotype. So make sure that you send several and not only one.
I don't think 4 millimeter.
No, it's not. But if you want to save money, you send one. And if you would have chosen the 3.4 centimeter, which was with the lowest score.
Yeah, but you send it not because of the size.
I know.
You send it because of the grade.
Right.
This is additional information that you have to make sure.
Thank you very much.
You're welcome.
Very good case. Dr. Irena. I'm sorry I will do my best. Thank you.
בסדר? בעברית? אז זה for... זה הכי קל. כן, זה 44 old young patients, healthy, with invasive secretory carcinoma. Secretory carcinoma is usually the carcinoma with very, very good prognosis. Tumor size 1.4, ER strongly positive 5%, PR negative, R2 negative, grade 1. KI of this tumor, the 5%, but one lymph node with micrometastasis, 0.3 millimeter. Questions: yes or no hormonal therapy, yes or no oncotype, yes or no chemotherapy,
Great question.
secretory cancer.
Secretory cancer. So, I am very much a believer in evidence-based medicine and looking at the data and basing recommendations. And and being very honest about what we know and what we don't know. In this case, it is very easy for me to be very definitive and say we have almost literally no experience in testing for secretory carcinoma. I will not keep you in suspense. We would not recommend ordering Oncotype in this patient. Secretory carcinoma. No, it's interesting. It was a tumor. It was a tumor that in the past was originally reported in young patients, but it can occur in men or women at any age, although it occurs in young women. It's associated, interestingly, with a very favorable prognosis. It is most often triple negative. And actually, there was a report about a year ago, and I'm going to talk a little bit about our own next generation work, but in some of these patients, a translocation has been reported between chromosome 12 and 15, if I remember correctly. We actually, since they're almost all triple negative, had none of them in B14, none of them in B20. And even when we look at our large database of 420,000 patients, have almost had none that we've identified to date. And so I would say that in this case, this is where the art of medicine, and I'll talk a lot tonight about the importance of the art of medicine. The art of medicine does not go away. Oncology is going to increasingly become how good we are with smaller or rarer entities. And so what did you actually, I guess, how many of you have had much experience with secretory carcinoma? Second case here. Maybe what, 1 or 2 cases in all of Israel every year. I mean, so what did you do? You want to? Yeah. You did MammaPrint. Oh, now I have a headache. It's triple negative. And so what happened with no evidence? Yeah. Yeah.
After
Yeah.
MammaPrint,
Yeah.
high risk recurrence score 39%. High risk. After
She was
MammaPrint,
high risk after
high risk,
MammaPrint.
39%.
In the MammaPrint, all high risk are the same number.
Comments?
Now they're going to stop giving us percentages. They're going to,
For the moment, it's all high risk in the
I
same
don't
number.
send it.
Comments?
What can I do now?
Yeah. Yeah. Yes.
Maybe it is one of the good subtypes of triple negative. I would do an androgen receptor stain for that woman. Again,
Interesting.
yeah.
Yeah.
Some of
Interesting.
these subtypes with the
Yeah.
AR. I would not order MammaPrint, I think.
Came to you for second opinion with the MammaPrint high risk. What would you do?
She has to, otherwise.
I must say I wouldn't do MammaPrint, and even with the answer, I wouldn't do it.
Yeah.
That's a 1.4 centimeter. Grade 1 tumor with micrometastasis.
Oncotype, yes or no?
No.
But I'm not MammaPrint.
No, strongly positive, 5.
For me,
Yeah.
the ER positive of 5% is negative.
Yeah.
Yeah,
Yeah.
because there's also
Although-
a paper lately on
Although in the States, above 1% is considered positive, I think it's nonsense.
We just reported.
just a paper. Just,
Go ahead, and then we have some data on this too.
I'm saying there's just a page.
I just want to.
Just a paper that came out, I think, from MD Anderson, that they checked the very low expressors, 0 to 9, and then above 10, and they said the 0 to 9 is basically triple negative. So,
Dr. Baljeet.
I think in JCO, yeah.
Dr. Baljeet Singh looked at a cohort of patients at NYU that were 1 to 10% ER positive by recurrence score. A large number of them were indeed found not to be ER negative.
I must ask the pathologist.
Yes.
I'm old. Maybe. I'm old enough, and I've seen in my 40 years. I've seen in 40 years of career, maybe four secretory carcinoma. They were all considered to be, according to our pathology, DCIS. לא?
DCIS זה קרצינומה אינסייד.
אני יודע.
דיסקטרי קרצינומה זה קרצינומה פולשנית. אתה לא יכול להגיד על דיסקטרי קרצינומה DCIS דיסקטרי קרצינומה כקרצינומה פולשנית. אתה לא יכול להגיד אינסייד כשיש סביבה קרצינומה.
נועה, אני אמנם אחרי קצת אלכוהול, אבל אני יודע מה אני מדבר. Intracistic is DCIS. But I know, but I've never seen a report of the fourth time of invasive secretory. It was written secretory, parenthesis, DCIS.
There is another type of...
invasive secretary into pathologies.
Okay,
Yeah.
I'm saying that all the cases I've seen,
Yeah.
that's what I've seen. Now, they don't send medical metastasis, but this is a lumpectomy. This is not a mastectomy, Rafi. So it might be that she has another tumor in the breast that have sent the micrometastasis.
Okay, good. Well, very good discussion. If you're wondering, I said that I wouldn't recommend Oncotype. If you're wondering also, I would not recommend Mammoprint in this case either.
Did you give her chemotherapy or not?
I don't know.
It's new.
It's new, yeah. Yeah, there is another type of cancer. I asked our pathologist, are there other very rare types of cancer that I have not heard of? Because, this is not very common. And there's also an adenoid cystic type of breast cancer as well. And that tends also, right, to be triple negative with a good prognosis. So we are not still so smart yet. And some of these, rare tumors, I think, are going to teach us that the biology that allows cells to proliferate in the breast is not necessarily the biology that allows cells to proliferate in the liver or the lung and other tissues, and biology matters. And maybe that is what is going on in secretory. It's triple negative, but the stem cells in this case do not know how to thrive and grow at distant sites. That is just speculation. Maybe we will figure this out. But thank you. Thank you very much.
Just chemotherapy in this case?
Me? I do the test. No, I generally don't recommend treatment. But if I was in this case, looking at this, I would be looking at, not so much the genomics, but the published literature of clinicians' experience, and looking at what they teach us about what we should do in cases like this, and rely on those rare cases in the past. Okay? And the wisdom of your colleagues here in this audience, yes, as well. Okay, good. Great case. Thank you. Let's give her a hand. That was really good. Yeah, okay. So, Dr. Pericon, please.
While she was nursing her 35-year-old daughter with a triple negative carcinoma of breast, she palpated, this 62-year-old lady palpated a lump in her right breast. It was biopsied. It was found to be a grade 3 carcinoma, receptor positive, ERB2 negative, and a positive lymph node was found as well. She underwent a lumpectomy and axillary lymph node dissection. It was a T2 grade 3 carcinoma, 3 out of 20 lymph nodes positive. We see pathological results of tumor penetrating into vessels and lymphatics, but we very rarely see a description of lymphatic and blood vessel malignant emboli. It's an ugly picture. So we discussed her in our conference, our oncology surgical conference, and we decided to give her chemotherapy. As we were discussing it, her oncologist informed us that she decided to pay for her own oncotest because her HMO does not cover these things. It still doesn't. It still doesn't. Not a large grade 3 and not a positive axilla. And we decided no matter what the oncotest will be, some sort of chemotherapy will give her. So she paid for her own way. She's very well informed. Where's the next slide? Okay. And the recurrence score was 20. As ugly as this pathology is, it was 20. Our decision was to reduce her chemotherapy from 4 ACT to 4 TC so that she could start her hormonal treatment as soon as possible. It's 4 years ago and she's fine so far.
Was I a partner with you?
Pardon?
Was I a partner with you?
Absolutely.
For chemotherapy with RS of 20?
No, we didn't know that. היא שלחה. She sent it. עם תמונה של טומור אמבולאי בכלי דם וכלי לימפה.
First of all, the question is, would someone, except me, would ask for oncotype in this situation? Because I would.
I know you would. That's why I suggested to her that she does it, and she did it.
HMO, it was paid. 3 HMO are paying for 3 nodes, never mind the size of the nodes.
True.
Never mind the grade. One of the HMO is not paying. Okay. I would ask for with RS of 20. I would give only a
This case was presented in front of approximately 100 oncologists and surgeons in Europe. And some, I don't remember his name, some American oncologist said, I don't think there is one doctor in this forum, in this cohort, who has the balls not to give some chemotherapy in such a case. So I guess you would.
Yeah, I would, but and I don't understand. You know, it reminds me of the Bernard Shaw joke. If know your profession now will decide upon your price. To reduce chemotherapy because of oncotype. אני יודע שלא בן אדם יכול To reduce the dose of chemotherapy, it's either to no chemotherapy or to know your prevalence. Oncotype doesn't give you chemotherapy with the kind of chemotherapy. You know, it's the prostitute. It's how much you are paid for. That's the profession. Now we discuss the price. With RS of 20, why chemotherapy? And to reduce it was in the middle of the treatment, I understand.
No. We decided she would get some sort of chemotherapy, no matter what the result was. It's all, and when the result came in, it was changed to 4 TC.
And I guess to talk about the rationale, the thought was that more aggressive chemotherapy might be associated with greater toxicity and maybe...
And would delay the beginning of hormonal treatment.
The differences between the chemotherapy are so negligible. So it's either yes or not. TC, ACT, those dense...
I'm the surgeon.
This is only... And I don't remember the details of Katie Albine with up to 3 nodes. But the recurrence score showed that CAF is as good as tamoxifen with this recurrence score. Sorry?
Yeah. So this raises...
I'm not sure.
Yeah.
I'm not sure.
So
I'm not sure. Below 18, I'm not sure.
So I'm going to come back to one of the features of this case in my prepared remarks. I'm going to talk a little bit about the cut points. I sometimes get asked, where did the cut point of 18 come from? Why do we have the cut points that we have? And because I think, one of the interesting things is clearly that that this is a 20, and again, 20, 19, 18, 17, 16, how should we think about that? What are doctors doing in clinical practice? And I brought a slide to highlight some of the data we've obtained recently that speaks in terms of how is the test being used in clinical practice. So let me come back to that. Clearly, the other comment about this one is that one of the rationales, certainly for both the TAILOR-X study and the responder study, two very large studies looking at the effect of chemotherapy, in this setting, is to get better definition potentially down the road of cut points. Okay. Thank you very much. Let's. Oncotype DX testing. Tanir, thank you.
Okay, so even though Oncotype is about decisions regarding chemotherapy, it can be useful for surgeons as well for surgical decisions. One of the HMOs does not allow OncoTest to be ordered by surgeons. It's probably the same HMO that won't do positive notes. But anyhow, so this is a 64-year-old woman in excellent health who came for what we assessed to be a 3-centimeter lump in her breast. And she has like a cup size B. So the ratio between the size of the tumor and the size of the breast was such that we figured would make a lumpectomy with clear margins a bit of a challenge. And she did not want to have a mastectomy. And this is a case that we discussed a lot, and I think the surgeons and the oncologists were not completely in full agreement in this case, so I'd really like to hear your input. My thinking was that if this was a high-risk tumor, if this patient would need chemotherapy regardless, we might as well give her chemotherapy up front, and that would help us to do a lumpectomy much easier. As it was, a lumpectomy in this case would require oncoplastic reconstruction or else leave a horrible defect. And it looked like a not quite luminal A because the Ki-67 was a little high, but it was low grade, ER/PR strongly positive. And we did go ahead and order the Oncotype DX before surgery, and this was the recurrence score. So assuming that we will maybe not give her chemotherapy, we went ahead and did a lumpectomy with sentinel lymph node biopsy and oncoplastic reconstruction. She had a little bit of postoperative infection, but nothing major. It was treated with antibiotics. She had a 340-gram lumpectomy. That's big. That's big. But she had a very nice cosmetic result. In the end, she had matching of the other breast. But that lymph node. Yeah, the tumor was larger than we had assessed.
I'll explain. Can I explain the case?
Go ahead.
Okay,
From the oncologist perspective.
Yeah. No, the case was a patient who was borderline for neoadjuvant chemotherapy, and Tanir wanted to see that if she's going to get chemo anyway, if the Oncotype had a high recurrence score, we would give her neoadjuvant chemotherapy and then do the surgery. But if she had a low recurrence score, if she has a low recurrence score, then we can go ahead and do the surgery because she will not need chemotherapy. So we have a slight disagreement. So Tanir went ahead and ordered the Oncotype, and she had a recurrence score of 12. I said 12, she will not get chemotherapy. She went ahead and did a lumpectomy and sentinel lymph node biopsy, and she had a surprise. because the pathology of the tumor was not 3 centimeter, was 6 centimeter.
And she might as well have the second lymph node.
Why did you consider hormonal
What? Neoadjuvant? Well, because she was operable. She was operable.
completely operable, and hormonal neoadjuvant, the
was operable. It wasn't-
the
it's not that
shrinking
she
of the tumor
wasn't
is a lot less
operable.
dramatic, and takes a lot longer.
Yeah.
And
Do we need dramatics?
well, if I'm
We need response.
no, you need response. But if I'm going to do the surgery and I want to do a smaller lumpectomy, I need it to be significant.
Nothing will happen to the patient. That's
No.
all. It's a-
Okay, but she was operable. She was operable.
That's not standard.
Neoadjuvant hormonal
Anyway, so she had the surgery, and then she came back with a 6 centimeter tumor with grade 2, not grade 1, with one lymph node which was over 1 centimeter, and I was not happy with me giving her only chemotherapy on a
Only
core
hormonal.
biopsy, and I asked to redo on the surgical specimen. And they gave me a hard time because they say we have full concordance between biopsy and surgical specimens. We don't want to do it. But eventually they were pushed into it and they did it, and it came back 12. So she got hormonal treatment and radiation treatment and radiation therapy. She did not get chemotherapy.
Good. Well, let's. So actually, in talking about neoadjuvant endocrine therapy, it is actually not very popular in the United States either. It's not popular primarily because of the desire sometimes of patients and sometimes of physicians and sometimes of both to have responses quickly. I think that's, what was highlighted. What's challenging about giving neoadjuvant hormonal therapy is that the change in tumor size takes place over a longer period of time. In terms of the way we think, though, about cancer today, it's the biology that matters. And so clearly, this is a great case of highlighting what we don't know in this case. Although the tumor was very large, although there were positive nodes, what we don't know, did this patient have mammograms regularly? By the way, do we know? We often don't know. Do we know how long it might have been there and, without coming into you to see you? We don't know. That biology could have been there for a long time. And that biology might never change to cause her to have anything other than hormone-responsive disease for a long time. And that's what we hope.
Shula Rizel once.
Yes.
We're old enough. So 20 years ago. So the larger the tumor is with grade 1, the chances that she will have lymph node metastasis
Yes.
is a question of time.
Yeah.
Not of biology.
Yeah.
Unfortunately.
Yeah. This case, first of all, thank you very much for this case. We've actually published now and in collaborations with 2 groups in Japan who actually find culturally a great attraction to doing neoadjuvant endocrine therapy. And clearly those published studies highlight what you would expect, which is the greatest benefit, if we look at prospective, retrospective results, of neoadjuvant hormonal therapy comes with low recurrence score disease. The other thing I want to do, actually, my wife is in the audience here today, and this was 10 years before I started working on Herceptin, but breast cancer touched our family as well. Her mother was diagnosed with breast cancer in New York at the age, we were out in California, at the age of, she was 66 years of age, so she was born in 1919. So that was 95 years ago. And she came from an era that even talking about breast cancer, right, was something that women in New York didn't do publicly. Actually, she presented with a very large mass, multiple nodes positive, strongly ER/PR positive, had good surgery in New York. At the time, we had a a 1-year-old son and a 4-year-old daughter. And she had a dream, to be able to share her life with them and with us. And interestingly, she never had an Oncotype, by the way. I think some of you are wondering, although, to be honest, in light of all of this, I sometimes wonder, and I wonder, what the informed consent would have to be. But in any case, what's interesting is that, she had, a very bulky tumor, a lot of positive nodes, strongly ER/PR positive. Went 14 years disease-free after local therapy. Presented then after 14 years with metastatic disease, continued on hormonal therapy and lived for another 8 years. So lived 22 years to the age of 88 and managed to have a great life with us and with her children. So biology matters. Yeah, so thank you. We have another case. This is 40. This is, again, now we're switching to a younger woman, 45 years of age. And who's going to present this case? Please, thank you.
I prepared two cases, but this one I think is a continuation from the previous one. It's 45 years old premenopausal woman. She's healthy, from Tunis origin, with family history of breast cancer, but non-carrier of BRCA1 and 2 mutation. In May of 2013, she discovered the mass in her left breast. In clinical examination, it was a mass 5-6 centimeter in the middle upper part of the breast and fullness in the axilla. This is in mammography, there were only benign type of calcifications. In ultrasound, lesion of 4.5 centimeters, and a lymph node with thickened cortex in the axilla. Lately, we did MRI because it was infiltrating lobular carcinoma. This is the picture of the MRI. Okay. In TrueCut biopsy from the breast lesion, it was infiltrating lobular carcinoma, as I said. No.
According to the previous slide.
No. It's mammography, ultrasound, and MRI in the same breast.
Multicentric.
This is the same breast. And there was 2 lesions, one big and one small in the MRI. We didn't take TrueCut from the small lesion. We took it from the big lesion. It was ER strongly positive, +3 in 100% of the cell. PR, the same one. HER2 negative, okay, 67 was positive in less than 5% of the cells. In FNA from the axilla, we found malignant cells. Systemic evaluation was negative. The patient planned the trip to London for 3 months for the family reasons, and she can't undergo operation in that time. We planned mastectomy anyway. That treatment, it wasn't not a neoadjuvant actually, but we have had to treat her in the 3 months to care the 3 months of her trip abroad. She asked me about, I planned a hormonal treatment, I must say, and she asked about Oncotype DX, and she wanted to do it. She paid for it, doesn't matter, and recurrent score was 9. She began to receive LHRH agonist and tamoxifen and fly to London. She came back in 3 months.
It was minimal response clinically and in MRI. It took another 2 months to prepare for the operation, and she continued hormonal therapy. And in the January 2014, she underwent left radical modified mastectomy with reconstruction. And you see the pathology from the tumor is what exactly the same as true cut biopsy. But we found 8 out of 13 lymph nodes in the axilla. Okay. Now the question for all of you and to Dr. Shak. 8 lymph nodes doesn't exactly 45.
40.
According to 5 or 6 months on hormonal treatment. Per guidelines, she has to get chemotherapy. 8 lymph nodes doesn't exactly make her sensitive for chemotherapy with the biology of the tumor and recurrence score of 9. How will you treat this patient?
Yes. Microphone.
I think that the answer is in the liver. After 6 months of hormonal therapy, if you have residual disease, either in the breast or in the lymph nodes, especially in the lymph nodes, she should receive chemotherapy. She should receive chemotherapy.
I don't know. How will we know?
We don't know if she is hormone responsive or not, but we know that at least very high,
High risk?
at least according to, I faced this problem about 7 years ago with a wife of a doctor in my hospital. She had hormonal therapy for 6 months with an oncotype of 57. 57, not less than that. Lior knows her name and Bella also. She, because of some reasons, she refused chemotherapy at that time. She was responsive to exemestane in 2 weeks, in complete disappearance of the tumor in the breast and in the lymph nodes. After 6 months, she agreed for operation. She had a tumor in the breast of 1.5 centimeter and 3 lymph nodes, and a journal published then in JNCI advocated chemotherapy, and she received chemotherapy without the exemestane. She reassumed the exemestane afterwards. So I think this woman, 45, she should receive chemotherapy. Which one I don't know. One of them.
How you explain this biology and our decision? It's low proliferative tumor. Okay, thank you.
Yeah, thank you. So the best data we have on this doesn't address premenopausal patients, but in the SWOG study, we looked at node-positive disease and clearly looked at the benefit of chemotherapy as well as prognosis. What was very notable is that patients with small numbers of nodes, especially 1 or 2, could be thought of not very different from the way we think about node-negative disease. But with 4 or more nodes, although we couldn't show in that study, and there were, again, only a small number of patients, that was a benefit of chemotherapy, so we're not sure. What we do know is that the risk with 4 or more positive nodes in ER-positive disease of a recurrence, which is not curable, is actually quite high. And so that leads me, and I think most of us, to recommend being more aggressive and to add chemotherapy in most patients who are 4 or more positive nodes. Now, that being said, I'm still sure that there's the case for a conversation and sometimes considerable thought about whether that's the appropriate thing to do, especially if there might be other circumstances. But I think in the typical case, I would agree with the comments of you in this case.
On other hand, we know that chemotherapy benefit small in so high estrogen and progesterone
Right.
receptors. Benefit very small.
Yeah.
We know this part.
Right. And she's now a younger woman, so I think it's a bit harder in this case as well, not to respond to the finding of so many positive nodes.
It is difficult to understand. If you believe, and you believe in the test,
Yes.
and the test shows that biologically she's non-responsive to chemotherapy. So
great
why to give her
question.
chemotherapy?
Yeah, so the question is, do I believe or know that there's 0% benefit in terms of relative risk reduction, or might there be a 5% relative risk reduction? And if there's a small risk reduction, if the risk starts out much higher, then that might be a small absolute benefit. And so that's the way that I think about it. I think about it in terms of what the absolute benefit might be. Now, clearly, if the risk is much lower, then a 5% relative risk reduction is nothing. And in that case, we can, again, with small numbers of nodes or with no negative disease and low recurrence score, be very confident that there's minimal or no benefit of chemotherapy. But if the risk is 40%, then even a 5% relative risk reduction might be a 2% absolute benefit. The larger studies, Responder and some of these other studies, will help us define how confident we can be about that. My own belief in the long run is we're going to find very little benefit in low recurrence score disease.
Why do you say she's not responsive? She had a huge mass on MRI and it's
Yeah. Oh, yes. Yeah. Yes. So absolutely, let's continue hormonal therapy in this patient, and it's likely to be, and we can tell her, which is great, that it's really important that you continue your tamoxifen, that's likely to give you the greatest benefit over the long run. And that's probably an important point to emphasize. Yeah.
I think we've discussed this in the past ones, but when you look at the recurrence or you look at the breast tumor.
Yes.
Breast tumor. Now, the lymph node metastases might have different biological properties.
Yeah.
Have you looked at recurrence work in lymph nodes?
Yeah, so we've done a little bit of work on that has led us to recommend not to send in the lymph nodes to get a reliable result. And the reason is that there's sometimes very high dilution of the profile by lymphocyte RNA. And lymphocytes are very metabolically active, right? They're, germinal centers, all that activity. And so we can't be confident that the profile we see hasn't been contaminated by not a couple of lymphocytes, but as you know, when you look at a node, you can sometimes see abundant lymphocytes. Now, we and others have done some research work that actually says that, first of all, as I think about the biology, the lymph node to me is a marker. And teaches us about prognosis, maybe, especially with large numbers of nodes, but is certainly nodal status is not predictive of chemotherapy benefit. And we now know that in terms of clinical consequences, probably what matters, and I'll talk a little bit later about this, right, in terms of the future, cells have been circulating in the blood for years and years, prior to diagnosis. Probably it is those cells that get out into the periphery and whether they have the biology to thrive that matters in terms of chemotherapy benefit or response to hormonal therapy. And so that's certainly the direction we're headed, is to focus on trying to study circulating tumor cells or what we can learn from the blood and study that as we go forward. Most people have looked at lymph nodes and have seen that, at least in terms of a lot of the markers, they're very similar. Okay. Well, first of all, again, thank you for that presentation as well.